Welcome. In continuation with the head and neck teaching program we are doing, we are in the last 3 talks to complete the program. So today we have a very senior medical oncologist from HCG Cancer Center, Bangalore, Dr. Satheesh CT, who is going to cover on what are the various options available in head and neck. Now this is not just an era of chemotherapy. Now this is an era of immunotherapy, targeted therapy. After a lot of randomized controlled trials on cetuximab, then nivolumab has opened up. The option in head and neck is tremendous now. So Dr. Satheesh will cover what is a medical oncologist options in squamous cell carcinoma of head and neck. Thank you, Satheesh, and welcome, and over to you. Satheesh, audio, we are not able to hear you.
Sir, can you hear me, sir?
Now we can hear you. Welcome,
Yes,
and
sir.
over to you. Please start.
Yes, sir. Sir, thank you, sir, giving me an opportunity to talk on head and neck cancer, the role of medical oncologist in head and neck cancer management. Coming to the introduction, that just I want to talk a few words. Head and neck cancer management is mainly depend on the multidisciplinary teamwork. Mainly, the majority of the teamwork is main center of the work is a surgeon, head and neck oncologist, surgical oncologist, and with the help of incorporating the medical oncologist and the radiation oncologist. Definitely, we can improve the curative treatment and especially functional outcome of locally advanced head and neck cancer. It is medical oncologist being incorporated in a various way. You can see here various following headings will deal. Induction treatment. You should know that what you mean by induction treatment and neoadjuvant treatment. See, induction treatment, it is a systemic treatment is delivered before the administration of local treatment in the form of radiation. Neoadjuvant treatment, it is a systemic treatment delivered before the treatment of surgery. The anterior part of treatment will say oral cavity. Now, in stage of oropharyngeal, also availability of advanced technology of radiation, like surgical, that in the form of robotic surgery. That now we can give anterior chemotherapy, that is neoadjuvant treatment will tell. And the next is the posterior part of a head and neck tumor will be dealt with the concurrent chemoradiation. That is a multidisciplinary approach, because sometimes we may go definitely chemoradiation most of the time. Sometimes it's a locally advanced disease, is a bulky disease. It is with a multidisciplinary approach with the MDT team. We may go with the induction treatment followed by concurrent chemoradiation. And next is that of course metastatic setting is a palliative chemotherapy or with a combination of immunotherapy or single agent immunotherapy with a target therapy will be dealt. This is the current treatment options is a local advanced how we do stage 3, stage 4 treatment. Stage 3C is directly is coming in the palliative setting. Is wherever possibilities we'll try to go for a systemic treatment and local treatment also incorporate to improve the longevity of treatment and functional and quality of life. See that I said about the surgery-based treatment in the form, especially anterior treatment, like post-surgery, then we'll go for adjuvant role of adjuvant treatment. Radiation is there mainly, and chemotherapy will be incorporated, like wherever indication of chemotherapy is required. Like in this setting, like there are patient may not be fit for actual concurrent chemoradiation cisplatin, because ineligibility for a cisplatin we might incorporate different protocols. If we come into the other one is a RT based treatment, like it can be going for a concurrent chemoradiation especially posterior part of treatment, or maybe sequential therapy in the form of induction treatment and followed by concurrent chemoradiation. Concurrent chemotherapy can be like cisplatin based treatment, otherwise biological agent with the radiation, sometimes maybe a single agent like that, single therapy, single modality in the form of radiation. Sometimes patient not fit for anything or early stage can be even go for a radiation alone also. That is RT based treatment. The concurrent chemoradiation, what I said is like three more options can be there. Concurrent chemoradiation with a cisplatin or biological agent with even adding a concurrent chemoradiation or bioradiation also can be there. Coming to the role of neoadjuvant or like a neoadjuvant chemoimmunotherapy. Some like if you're going for a surgical options, we'll call as a neoadjuvant. If you're going for a radiation based treatment as a local treatment, as a local definite treatment, we'll call as a induction treatment. We'll try to go with the older era as with the chemotherapy. When the evolution of treatment has started, it is with the methotrexate single agent, then later platinum based treatment combination of 5FU and cisplatin based treatment has come. Then that has made a change in the head and neck treatment, especially that the induction has started in the laryngeal tumor first, cisplatin 5FU, and later TPX protocol, that is TFF regimen has come, docetaxel, cisplatin, 5FU based treatment that has taken over. But most important thing is we are not able to treat everyone with the TFF protocol patient because the performance status, fitness to the treatment, and so much of comorbidity, like not able to take even a cisplatin based treatment. We may go for a paclitaxel carboplatin plus or minus sometimes 5FU. We might go. This is the protocol we try to use a systemic treatment when you are dealing with the neoadjuvant treatment. Sometimes we are biology of the tumor is a hard tumor, a cold tumor, and even PD-L1 expression. The protocol, lot of evolution is there, and newer protocols are incorporating, even adding biological agent, systemic the biological agent in the form of anti-EGFR inhibitor, that is cetuximab. There is a protocol is there, paclitaxel, carboplatin, and cetuximab. Like we might use it if it is a cold tumor, PD-L1 negative, is a bulky tumor. If surgeon want, especially a oral cavity tumor, we want a best response before going for the surgery. We might along with the chemotherapy, if you add cetuximab based treatment, oral response rate means that the tumor shrinkage will be better. We can give a best the surgical outcome, and margins clearance, and will become cosmetic outcome, functional outcome also will be better. In this situation, we might incorporate, because cost is a major problem in our country. Wherever possibility is there, like it is discussed in the MDT, and even financial thing also will come. If the financial is okay, not an issue, we might go with a cetuximab based treatment, pacli carbo, or even a docetaxel cisplatin TPX protocol will say. This is the neoadjuvant treatment is given in the locally advanced oral cavity cancer. Next is immunotherapy will be incorporated, like it is being evolved in the head and neck cancer, in various other cancer in the body. It is been approved, FDA approved in a recurrent and advanced head and neck cancer, failure to the definite treatment in the form of cisplatin, chemoradiation, or post-surgery, the post-surgery radiation. Now it has been tried in a various cancer as a neoadjuvant in breast cancer, and even stomach cancer, and rectal cancer, various other cancer. Melanoma has been approved now. Neoadjuvant treatment of immunotherapy, single agent also they used, or combination of nivolumab, ipilimumab. There is a data is there. Is not is a neoadjuvant immunotherapy in a head and neck cancer is evolving. The most of the important treatment right now so far is a neoadjuvant chemotherapy. Wherever the bulky disease there, where a surgeon feels that I want a shrinkage of tumor with the help of where the medical oncologist will come in a picture, chemotherapy along with the biological. If a heart tumor or PD-L1 tumor is there, we'll try to go with the chemotherapy along with the along with the immunotherapy, immunological agent will be used, immune checkpoint inhibitor. There is a protocol is there. There's a phase 2 data, Paclitaxel, cisplatin, and the newer immunotherapy, and there is a small series of protocols are going on. That is a new cisplatin, docetaxel, along with the nivolumab also, and Paclitaxel also is there, and even a single agent nivolumab also. There is a 2 cycle of new agent nivolumab also, followed by the local treatment also is there. Various protocols are evaluating, but I'm coming to later, what is the things like advantage of chemotherapy is when you are using a induction treatment to the RT, it may reduce the volume and increase the local regional control and improve the organ function prior to the radiation alone or concurrent chemoradiation. Induction chemotherapy could treat subclinical distant metastatic disease without delaying, and especially in a patient with advanced disease, especially very bulky lymph node, whom we are expecting a distant failure is common. And a favorable initial response to the induction treatment definitely is one of the biological marker in the every patient, every individual. It predicts the efficacy of further functional organ preservation therapy, such as a chemo radiation. They're without going for any even some of the patient we can go for even without surgery, where they are not willing for surgery. Also there we can is an alternative therapy, and also even radiation. If you are going for surgery, also it is acts as one of the biological response, biomarker. Okay, this patient is like to have a long-term good results. How we are doing in the breast cancer like that, and administration of the chemotherapy concurrently with radiation may sensitize the tumor to the effect of radiation, and thus overcome the radiation resistance also. That's why it is going to be helpful for the adding to the local therapy. Sequential therapy, that is combination of chemotherapy followed by chemo radiation. It may combine benefit of both induction treatment and concurrent chemo radiation. It is a very interesting thing. The only issue here is the post induction treatment. When you're going for a concurrent chemotherapy, we might end up with the toxicity problem. Let's see that how we have to do whatever protocols are available, and the disadvantage is it may limit the patient compliance and delay in the prevent of subsequent local treatment. Sometimes what will happen, patient tumor shrinkage is very good, they might disappear, they may not turn back, compliance may be issue, then the curative treatment might prevent the surgery may not happen or radiation may not happen, then the failure rate will come. This is the one thing, compliance maintenance and the patient education, day one counseling is very important, why we are doing all this treatment. And when the tumor is already destroyed the organ, and a functional organ preservation may not be appropriate, where surgery is indicated. Generally the surgery is indicated when you want to go for a surgery. Okay, surgery margin clearance, all the thing, functional outcome, they're laryngeal cartilage and this thyroid cartilage, they're all destroyed. There's no point in I'm going to preserve the organ. Their surgery is the main role is there, a surgery you have to go ahead. Okay, that's what the aim of functional organ won't come when the organ destruction is there. There we have to go, surgery has to go. We might give the chemotherapy, that's to reduction of our tumor size, help for the margin clearance, and make that is all. It comes with the multidisciplinary discussion. Coming to that induction treatment, that is a various protocol. What I said is cisplatin and the 5-FU protocol initially came in the laryngeal tumor, and later docetaxel, the TPF protocol has come. And that has become a standard. It's given a better results than the 2 drugs. 3 drugs is better, but it's practically is not able to use these 3 drugs in all the patient. We have to be careful. It has to be discussed with the medical oncologist. Definitely they'll try to see that is a functional status, performance status, and on comorbidity. And then if the patient is not fit, you might go weekly based schedule with the paclitaxel, carboplatin, or cisplatin based treatment. And coming to when you're going for a 3 drug, the combination, it is really superior or not. 5 randomized trials are there. It's a meta-analysis done in head and neck cancer with the median follow-up of almost nearing 5 years. Hazard ratio of death, that is 0.79. It means that is the absolute benefit of survival rate like 5 years is almost 7.4%. In favor of that three drugs, that is a taxane, that is a docetaxel, cisplatin 5-FU protocol. Heterogeneity significance was there, but it is related with one trial. Some heterogeneity was there. There no much heterogeneity in exclusion of one trial. Their hazard ratio has come like 0.72 in favor of about that three drugs. There is no interaction between the treatment effect or following the treatment variants, like in the form of age, sex, performance status, tumor stage, and site. Obviously, that when you're coming, that fitness for three drugs may not be feasible in our intense scenario, because when elderly patient means like we will not go with the three drug aggressive regimen. We might give it three drug in a weekly schedule also. We might do it. There are some new protocol modification will be done by the medical oncologist, and based on the performance status also, and the we might change the protocol. Yeah, now is audible.
Yes, sir. Now it's audible, sir.
Yeah, okay, sorry. Okay. Yeah, coming to that immunotherapy. Immunotherapy, I said about the various immune checkpoint inhibitor is being tried. Nivolumab single agent and in the neogenicity, and even pembrolizumab also has been tried in the in cooperation with the radiation, and avelumab also is there, and along with that various newer drug about the pembrolizumab, that is being tried with the nab-paclitaxel and cisplatin-based treatment in local advanced head and neck cancer. This is one of the phase 2 data. Resectable advanced head and neck cancer between the T2 to T4 with N0 to N3B. with the M0, neoadjuvant chemoimmunotherapy with this newer drug, that is pembrolizumab, that is 200 mg with an nab-paclitaxel and cisplatin intravenously. It is done 3 weekly, 3 cycles were done. The response were very tremendous. When you are coming with the chemotherapy alone, it may not be achieving this much. That is almost like 89% among the 48 patients. Those who completed neoadjuvant treatment. Out of these, 27 patients underwent a surgery. 17 were achieved almost maximum major partial response or partial pathological CR. Pathological CR rate was almost like 55.6% was there. Treatment related side effects were like the grade 2, majority of grade 1, grade 2, grade 3, grade 4 were there in the 2 patients only. It's a very less number. That is primary endpoint of this study was like it was met acceptable safety profile. It was is feasible toxicity wise and definitely it gives the good pathological response. And these trials are newer studies, phase 3. We are waiting for phase 3 trials are going on in head and neck cancer with the combination chemotherapy, and definitely is going to be game changer in the head and neck cancer. That even operable cancer also going for a neoadjuvant chemotherapy. How we are doing in head and neck like breast cancer and other cancers. I think that is going to come in a picture in the future, that chemoimmunotherapy. Right now, chemoimmunotherapy is being approved in the locally advanced and metastatic head and neck cancer. And this neoadjuvant setting and even adjuvant setting, there all trials are going on. We are awaiting for this results in the future conference. Coming to the definitive treatment is a concurrent chemoradiation. Radiation, I'm not going to deal this. Maybe radiation oncologist already dealt till now, and the medical oncologist role has come in a concurrent chemoradiation in the definitive chemoradiation in the especially posterior part of the treatment, or maybe adjuvant treatment after the post surgery when a high risk is there, where we are going to go for the adding the adjuvant chemoradiation. And there is a like a post induction treatment there, like concurrent chemoradiation will be done. This is the options or agents are available. Definitive chemoradiation, that is a cisplatin based treatment, is a standard of practice. There is like because still we are going to see the failures, that to improve the outcome there is a protocols outcome, that is adding additional agent in the biological. There is a the additional like biological agents are added, and even the immune checkpoint inhibitors are added to improve the outcome. Let us see that what is the conclusion from them. Then the major challenge is like in our Indian setting is the cisplatin ineligible patients, how we are going to deal. And adjuvant treatment, yeah, definitely cisplatin based concurrent chemo is a standard of practice. Sometimes like we don't have data supporting robust data in this, like still we might deal with how we are doing that. Data is like case series are there, but in adjuvant treatment in cisplatin eligible, we might try how we are going to deal today, day-to-day practice. And post-induction, cisplatin is standard treatment, but only thing is a tolerance issue. We might land up with a biological or various cisplatin eligible protocol, we might go. This is that various trials, like it's been evolved in the head and neck cancer, that radiation was a standard treatment when the treatment was started in the head and neck cancer. Then various agents, it can be single agent to the combination like agents, like adding systemic treatment along with the radiation definitely made the survival benefit you can see here compared to the radiation alone, and local regional control definitely has improved compared to the radiation alone. That's why it's become a concurrent chemoradiation has become a standard of care. Combined modality incorporating both the chemotherapy and radiation improved the results compared to radiation alone. Achieved improved or equivalent to like overall survival compared to the local regional therapy alone, or that surgery or radiation definitely has improved the outcome. And updated meta-analysis of this concurrent chemoradiation protocol in head and neck cancer, having almost 71 trial, included 10,000 and odd patient, median follow-up of 9.2 years. CRT significantly improved the overall survival rate compared to definitive local therapy alone, with the various interval of 5-year and 10-year absolute survival benefit of 6.5 and 3.6% respectively. Hazard ratio was like 0.83. The OS benefit was due to decrease in the cancer-related death. It was influenced by the reduced rate of locoregional recurrence, not much distant recurrence in the concurrent chemoradiation. That's why that the sequential therapy they talk that induction followed by CTRT do that. Even you might even overcome the distant failure also. There is no increase in the non-cancerous death was observed in the concurrent chemoradiation, although longer follow-up is necessary to avoid the long-term treatment-related complications. And there is no major difference in the OS was observed between with the different RT schedules. The radiation therapy they might dealt in even 1 day like one protocol or altered or fractionated protocols. There is no much difference in this meta-analysis. OS benefit was CRT was over the definitive local therapy as decreased with the increasing the patient age. No OS benefit was observed in the patient with the age of 70 years. You have to be very careful, like when you're dealing with a very elderly patient. I don't want to go bombard with the very toxic treatment in an elderly patient. That's what I said is they should be fit for this protocol. Then we might go alternative protocol in the for adding biological agent like in the anti-EGF inhibitor. Patient able to tolerate the therapy. This I can see that meta-analysis found a greater benefit of platinum-based compared to platinum-based chemotherapy over the other cytotoxic chemotherapy. The various regimens have not directly compared with each other, adequately powered to randomize the protocols. So far, that is the most standard drug is the cisplatin. That they supposed to over a period of concurrent chemoradiation, they should at least adequately the dose that is more than 200 mg per meter square. If they are able to achieve that, the patient is receiving, that is a very good benefit. That has been single agent concurrent chemo radiation with the radiation. Efficacy of platinum is a dose dependent, and higher cumulative doses having the more effective regardless of the schedule. The schedule can be even 3 weekly, wherever possibility 3 weekly schedules are fit patient we try to deal. Sometimes our Indian scenario we are not able to deliver a 3 weekly schedule of cisplatin. Their weekly schedule of cisplatin 40 mg per meter square will be you were using, but the accumulated dose, what I said is when I am going with a single agent cisplatin, the cumulative dose is that is 200 mg per meter square is more important. That is going to have improve the overcome. Coming to the adjuvant chemotherapy along to the radiation, there is a various randomized trials are there. Radiation alone with the chemo radiation. There is a combining the major trial of ERTC and RTOG trial. You can see there is taking the high risk factor when you are dealing with the adding the cytotoxic agent. See, in RTAG has taken 2 node positive has taken a high risk category. Both trials has taken margin positive and extranodal capsular extension is a major factor. That is the most indication for the that is a 2 factor is a indication for the adding the chemotherapy. And URTC is taken additional risk factor, that is the perineural invasion, vascular lipovascular invasion is there, higher the grade, and also 4 lymph nodes are positive irrespective of external capsular extension. Stage 3, stage 4, there the high risk factor along with the margin positive and extracapsular invasion. These are factors making us to add the cytotoxic agent along with the radiation when they are going for the adjuvant post surgery. There is a efficacy of cisplatin with the definitive chemoradiation as that's studied in India. That is in a protocol of that to see that weekly schedule is going to be is it give efficacy similar efficacy as 100 mg per meter square? It's an open labeled randomized phase 3 concurrent chemoradiation was done in India. Different dose schedules. 270 patients were there, locally advanced head and neck cancer, stage 3, stage 4A, stage 4B, squamous head and neck cancer were randomized to receive the definitive CRT either with a cisplatin of 40 mg per meter square for 7 weeks or 100 mg per meter square 3 weekly schedule of 3 doses. The primary site of this head and neck cancer was like oropharynx, that is 60%, larynx is 18%, hypopharynx and oral cavity was there, later like in a small number. Like oropharyngeal treatment, oropharyngeal tumor, their HPV positive rate was less, that is 13%, and the cumulative dose of cisplatin received more than 200 mg per meter square in the both the treatment, whether is a weekly schedule or a 3-weekly schedule, was almost near equivalent. There is no much difference. With a continued fall of 26 months, compared of this 3-weekly with the weekly, demonstrated the non-inferiority of loco-regional control at 2 years. That is the 53 versus 47%. Hazard ratio is 0.84, and PFS of 21 months, and OS was 26 versus 30 months. There is a marginal difference. The major important is the grade. That toxicity, grade 3 toxicity, was more frequent in the cisplatin in 3-weekly schedule when compared to weekly schedule. That is a mucositis, you can see here, 54 versus the 41%. And renal toxicity was a major important, and the GI toxicity in the form of nausea, vomiting is more prevalent in the 3-weekly schedule compared to weekly schedule. Patient treated with the 3-weekly schedule are also more likely to have more of treatment interruptions, and also requiring the repeated supportive care for IV fluid hospitalization and mucositis treatment. All the things were more seen in the 3-weekly schedules. Similar toxicity was seen in the other trials, but here our Indian trial, like that, it has shown that it is trying to have the more the tolerance was seen in the weekly schedule than the 3-weekly schedule. That's why we are majority. Absolute contraindication to cisplatin. The next other one is platinum based can be used, but is definitely going to have increased toxicity. There is a population at a risk of getting the more toxicity with the platinum agent. This is the cisplatin eligibility to have the criteria. So this is, like you can see the green one, you can say that is a patient is suitable for the cisplatin based CTRT. Age, performance status, and renal function, neurologically pre-existing any hearing loss, anything is there, because majority of our Indian patients are diabetic. They might be having already peripheral neuropathy and some hearing loss, fatigue and renal function also important, and cardiovascular dysfunction also there should not be there. Then the patient is suitable for cisplatin based, the platinum eligibility is there. There is other one, second category, that is known as the high cisplatin toxicity. Means you can use it, but the toxicity you're going to land up with is more toxicity. Age like above 70 years, performance status more than 1, and renal function is between borderline, that is a 50 to 60 ml per minute, and they're having a borderline of grade 1 toxicity of hearing deafness, the hearing loss, and like neurological toxicity, and fatigue and renal dysfunction. Cardiovascular also borderline is there, then we can use it. Absolute contraindication, if is there like renal function is less than 50 ml per minute, more than grade 1 toxicities are there, and performance status more than or equivalent to 2 is definitely we are not going to take for the is a cisplatin ineligible as contraindications here. The how I to improve this chemo radiation, improving beyond the cisplatin ineligible patient. See there and there is like cisplatin is a standard treatment for concurrent chemo radiation. There are various protocols they try to improve the additional agent. Means cisplatin come along with the cisplatin, can I add additional agent to improve the outcome? Still we see the failure in the cisplatin based treatment. Cisplatin eligible we try to deal in a different way. I'm going to come in the next slides. I'm going to come with like how I to improve the current treatment cisplatin eligible patient. There are various protocols. Cetuximab was added actually along with the cisplatin based treatment. There's a RTOZ trial phase 3. See, there's no improvement in outcome or PFS, but is added toxicity. That's why it's not approved. That it is going to add financially also, and even functionally also. Definitely a lot of mucositis and skin toxicities. So that's why cetuximab along with cisplatin we are not going to add. There is other one is like a concomitant boost the radiation and chemo radiation with the cetuximab. Is a phase 2 data here. Overall response rates are OFS things are like marginal increment is there, but stopped due to because of more of a adverse event or severe toxicity. That's why it's not recommended cetuximab adding to the ongoing concurrent chemo radiation. There is a one more phase 2 data. There also is causing the lot of radiation-induced dermatitis. Almost like more than 2/3 of patients, 73% of the patient. Grade 3, grade 4 mucositis is 64%. It really is a very challenging picture for any of us. That's why is more important is a very expensive one thing, and also toxicity. That's why we don't go with this addition of cetuximab to the concurrent chemo radiation. There is a one more agent that is known as the nimotuzumab. Can I add it? There is there's a phase 2 and phase 3 data from India. There is various series from the even Asian countries. We don't have a global randomized studies, but we have other agent to improve this like studies from India and other countries. This is a study from the Kidwai West trial. See, concurrent chemo radiation with nimotuzumab, we can see here response rate goes up almost up to 100%, and they're having a even 5-year follow-up data that is shown that it is not reached OS when compared to chemo radiation alone. You can see here, but it's a phase 2 data, numbers are less. That is the one important thing you have to remember. Definitely, this nimotuzumab can be added to the ongoing chemotherapy, that is concurrent cisplatin based treatment. Wherever high risk category is there, we can go with this agent. Then we can try to get even additional response, like additional local regional control, and trying to have an improvement in the meaningful OS. There is the TMH protocol in the phase 3 data for head and neck cancer, concurrent chemo radiation with nimotuzumab. You can see here that the primary endpoint at 2 years, PFS and DFS, CRT with the nimotuzumab CRT. You can see improvement in the PFS and even 2-year DFS rate. And secondary endpoint of local regional control also is definitely shown improvement by adding the nimotuzumab. And other OS data for second endpoint was also better. Numerically, it's improvement in the number wise, like even the statistical significance was not there, but other like they are all met the statistical significance, but OS was not. Numerically, it was showing the improvement, showing that local regional control and disease control, and they're all better by adding the addition of biological agent nimotuzumab along with the chemo radiation. And coming to that major thing is like because we know that HPV positive and HPV negative people, HPV negative OPC is a major challenge because HPV positive, they do respond very well with the chemo radiation. There the cisplatin based concurrent chemo radiation is going to be suffice. Actually, that is enough, and they try to do de-escalation, but right now still the protocols, the staging system is slightly different in the HPV positive versus HPV negative head and neck cancer. But HPV negative is a major challenge because they try to have a more aggressive disease compared to other subtype. Here, like you can see here, HPV negative tumor, like median PFS is going to definitely better with the HPV negative by addition of nimotuzumab. It is statistically very significant, and local regional control also is very significant here. It is as phase 3 data from the TMH protocol, TMH center. Local regional control is almost like a 60 months versus a 17.3 months, and OS also is like it's a dramatically improvement is there. The only drawback of this, the criticism of this protocol is the cisplatin dose what they used is 30 mg per meter square when compared to the other standard accepted protocol is a 3 weekly or like weekly 40 mg per meter square. That's one of the criticism. Like people, many of us we use this protocol 40 mg per meter square along with the nimotuzumab wherever the HPV high risk aggressive disease there, high risk of like you think that the CTRT is not going to completely going for a remission. We try to have some residual disease. We are anticipating in the day one. Definitely we try to incorporate this protocol in the HPV negative head and neck cancer. You can see here there is a 5-year OS data for this nimotuzumab also has come. Actually, you can see here nimotuzumab with concurrent chemo radiation with the only placebo controlled chemotherapy. You can see here the 5-year OS data was there. You can see here 70, almost nearing 75% versus 64%, and it is showing that definitely that is an improvement in the PFS data also. It is an improvement is there when compared to CTRT. Coming to the role of adding immune checkpoint inhibitor to the concurrent chemo radiation, there is a data for phase 3 data for pembrolizumab and avolumab is there. But addition of this program death inhibitor, that is avolumab to cisplatin based chemo radiation, didn't demonstrate the PFS benefit and phase 2 data. But only thing is there, just I want to say that if those are having any residual disease, because this is CTRT followed by adjuvant also, means continuation maintenance treatment has done. Maintenance treatment avolumab, it is showing the improvement in the those are not achieve the complete response following the CTRT. They are showing the improvement in the disease control. I'm not going like recommended to go for this avolumab, but didn't show right now CTRT radiation along with the chemotherapy. We won't go right now. We may go for later maintenance treatment, but not now with the CTRT. Pembrolizumab also shown this, like it is safer as what shown in the earlier clinical trial. Is failed to show in the improvement in the EFS when compared to chemotherapy alone in the phase 3 data. There's one important thing here is like in the HPV positive versus HPV negative, we can see here HPV positive OS like showing a better improvement compared to HPV negative, because HPV positive they try to have a like immunologically they're more better because virus induced tumor. How it is even CS cervix also like is coming and picture immunological agent is adding to chemotherapy showing the improvement in the overall survival rate. Here also it is HPV positive head and neck tumor. The pembrolizumab like try to show improvement in the OS overall survival rate. You can see here the HPV negative. You can see here there is a detrimental in the survival rate when compared to the HPV positive. And progression-free survival rate, HPV positive versus HPV negative. You can see here progression-free survival rate also it is numerically better when compared to HPV negative. You can see here there is a decrement in the progression-free survival rate in the HPV negative. Like so far there is standard of practice in head and neck cancer is cisplatin concurrent chemo radiation 3 weekly possible, otherwise weekly schedule will be done. Wherever high risk categories there, we can add even nimotuzumab if possible. But immune checkpoint is still evolving. We are not it's not become a standard practice. We are awaiting for still more the follow-up data of these protocols. Coming to the treatment of choice in the cisplatin ineligible patient in a locally advanced head and neck cancer. There is a various protocols are there. You can use a single agent carboplatin or carboplatin 5-FU based radiation, or paclitaxel or cetuximab radiation, or nimotuzumab radiation, or docetaxel radiation, or capecitabine radiation also, because those are not fit for cisplatin in a patient. You might come across actually even younger patient. Physically performance rate is very good, but cisplatin may not able to deliver because of the renal function is not good. Elderly, even the young patient is there, is hypertensive, diabetic, elderly renal dysfunction is there. These are the practical scenario in India we might come across. This is like a Bonner study. This is the phase 3 randomized study. It is one of the landmark study to come approval of this cetuximab. Here is a 424 patients, like a randomized study of radiation alone versus the cetuximab radiation It is a loading dose you have to remember is a 400 mg, 375 to 400 mg per meter square loading dose, followed by every week 250 mg per meter square, like up to 7 to 8 weeks of treatment will be there. It has shown that in the stage 4 non-metastatic head and neck cancer, adding cetuximab definitely shown in the improvement in the disease control. You can see 24.4 months versus the 15 months. It has shown the 44% improvement in the control rate versus the 34%. It has made in a landmark important approval of this drug in head and neck cancer. Those are like we are going along with the only radiation alone. And as cetuximab along with the radiation, definitely it prolongs the definitely prolongs that 5-year data of overall survival rate. Even though there is an increase in the radiation dermatitis, that you should know that how to use the toxicity management. And those who have even increased radiation toxicity, but still the disease control is very high. You can see here that the 5-year data is very impressive. That's what compared to radiation alone, still you can recommend. We are not going for a chemotherapy. At least you can, this biological agent also can be used. There's other GOTEC trial is there. There's a 1 and 2 that having a different numbers, and you can see here GOTEC 1 is a oral pharyngeal tumor was there. Here compared to conventional chemotherapy, carboplatin 5-FU was used along with versus the radiation alone. Here chemoradiation appears to be superior in the cisplatin eligible patient. That is PFS was numerically better. Hazard ratio was 0.82. OS also is shown better, but the toxicity is a major problem. That is almost 70% as the major toxicity, that is a mucositis. That's one of the leading contraindication. We may not use a 5-FU and carboplatin. We might use some of the patient carboplatin. There's one of the protocol is there. There's other one protocol known as the Pacli-Carbo, that how cross trial was used in esophageal cancer, even lung cancer as a concurrent chemoradiation is a Pacli-Carbo weekly. In a locally advanced head and neck cancer also protocol is there. 66 patient of median age of 70 age, that you can see here various subsets: oropharynx, larynx and hypopharynx. HPV positive was there almost 53%. T3 T4 disease was there. You can see here 2-year local regional control disease control PFS and OS rate was you can see 90%, and 93%, almost 88% are they are able to survive by an end of 2 years. Local regional failures are there, but conclusion from this weekly carbopaclitaxel is one of the other option in a patient who are cisplatin eligible, because is try to have a meaningful disease control when compared. We cannot compare across historical control. Try to have a meaningful control of the disease. And there is one of the phase 3 randomized docetaxel as a radiosensitizer in cisplatin unsuitable patients. It is one of the Indian study TMS protocol, and I can see here docetaxel was used. Here its important thing is the dose was used 15 mg per meter square weekly. Here with the follow-up of 32 months, the DFS rate was 30%, the radiation alone was 42% in the docetaxel. It is showing the improvement in the disease control. Median OS was 15.3 months, radiation alone versus the 20.5 months in the docetaxel. But one of the limitations is the toxicity here. You can see here no OS data of this, and a higher event of adverse event in the form of mucositis, and also the odonophagia and dysphagia was more common with the docetaxel when compared to radiation alone. This is one of the challenges actually we are dealing with the docetaxel based treatment concurrent chemoradiation in the cisplatin patient. And capecitabine also can be used, one of the alternative to when compared to the cisplatin. You can see here. Here overall survival DFS of 2 years, you can see here 67% and 88% with the capecitabine versus cisplatin when compared with the cisplatin. It is also tried to comparable whenever possible. Even case we are not able to go other systemic agent, we can even capecitabine also can be used. this is one of the the study is published in JCO, that is induction followed by, because what is the answer for the induction followed by concurrent chemoradiation? Cisplatin they try to use, cetuximab also they use it. This let us see this post induction treatment. What is the evidence of CTRT? There is a cisplatin protocol and cetuximab also is there. See that cisplatin is a standard of practice for a concurrent chemoradiation. Major challenge about the post induction, lot of toxicity, mucositis, and lot of treatment interruptions. That is and hematological toxicity. All the things are there. Here, like the cisplatin based, you can see here lot of toxicity here. When compared to cetuximab based treatment, is easily acceptable, except other than the skin toxicity of this cetuximab. This alternative, like in other one more protocol is there, like multicentric non-randomized study, post-induction cetuximab based radiation. You can see here, 3 year almost 70% of the patient is survival benefit with the following the cetuximab based agent, where like we won't change in any patient post-induction sequential treatment. We'll go cisplatin based treatment. Wherever a patient interruptions are there, rather than stopping completely radiation, you can go this biological agent can be used. Coming to the HPV positive negative versus HPV negative patient, definitely the HPV positive cases, definitely they try to have the mortality will be less compared to the HPV negative cases. The chance of mortality is very high, and mortality from the other second malignancy, all the things are high in HPV negative cases. This is one of the major challenge what we see. What are the any role of target agent in HPV negative cases? I said about nimotuzumab in what is published in the previous TMS protocol. I can use this along with the radiation cisplatin. You can use a nimotuzumab. Definitely is going to improve the OS benefit in especially oropharyngeal cancer. It is 2-year PFS. It is improvement by 25%, and local regional control also increased by 19%, and relative local regional failure also improves by 39%. 2-year OS benefit was increased by 18.6%, with the reduction of hazard ratio was 37%. This is one of the option actually. And there is evolution of a protocol in advanced tumor. Platinum based treatment is a major important protocol in head and neck cancer. Platinum based with the cetuximab, this is the extreme regimen. You can see here like a chemotherapy will go cisplatin 5FU, otherwise cisplatin 5FU with cetuximab followed by cetuximab maintenance treatment. This is the protocol will be used till the disease progression. Primary endpoint is OS and secondary endpoint is disease control, PFS, and quality of life and safety. You can see here 5-year OS, like the follow-up actually, that it is shows that scores for the chemotherapy cetuximab is shown the median survival rate of 10.1 months versus the chemotherapy alone 7.4 months. This is one of the landmark protocol for a baseline for head and neck, any recurrent untreated or metastatic tumor. Extreme regimen is one of the important regimen for the backbone of our chemotherapy in head and neck cancer. Say hazard ratio subgroup, like oral cavity, you can see here is definitely is improvement. Anterior treatment definitely responds very well with the anti-EGFR inhibitor compared to the posterior part. That has shown actually in a various protocols. This the results are validated from another phase 3 Asian protocol. Here also you can see that cetuximab based treatment compared to the only chemotherapy. Oral cavity, you can see that better disease control compared to other protocols. Actually, like cetuximab based treatment will try to prefer in the oral cavity tumors. Coming to the modification of protocol, because 5F is one of the challenges, and taxane also is more important in the treatment protocol in head and neck cancer. They try to do modification of protocol in the GOTEC study is there. That is a TPX protocol you can see here. Here, like first line recurrent metastatic head and neck cancer, extreme regimen, this is an older treatment, we used to use it. Now the newer modification, that is a cetuximab with the cisplatin docetaxel. The 4-cycle, here is a 6-cycle followed by cetuximab maintenance. Here is one of the other advantages, the maintenance become user friendly, that is a patient friendly. Patient can come 2 weekly maintenance treatment of 500 mg per meter square maintenance treatment 2 weekly. You can see here that extreme regimen 6-cycle followed by maintenance. Here is a 4-cycle followed by 2 weekly maintenance. Coming to the results, like a response rate is like almost nearing similar. The rate of progression is like less with the TPS protocol compared to extreme regimen. And the median OS you can see here, like extreme regimen is median of OS was 13.4 versus the 14.5 months. You can see here like a toxicity, like convenience. Actually the extreme protocol is like it is not convenient, is a single day I can infuse this TPS protocol compared to that extreme regimen. Grade 3 toxicity or grade 4 toxicity was more with the extreme regimen, and number of cycles like 4-6 cycles are more, like it is uncomfortable for the patient also. And patient plan to like receiving the like percentage completions are like less with the extreme versus the TPX protocol. Major contraindication cardiac toxicity is major important here. 5FA based treatment is causing more of cardiac toxicity, even GI toxicity also. Taxane based like a GI toxicity is important, that is we can able to handle it. And maintenance is friendly with the bi-weekly cetuximab based treatment. Coming to the second line treatment, that is extreme protocol versus TPX. Following that one, people they use they not use extreme regimen taxane, they can use a taxane. Cetuximab based treatment, those are not used at cetuximab based treatment. Overall there are various options. Immunotherapy also they use as a second line. And coming to the survival rate, those are randomized to reach like chemo versus cetuximab versus IO, like following the extreme regimen failure and TPX protocol. You can see here for second line, those are received following the TPX protocol. Survival rate is better, that is almost 22 months versus the 19 for 4 months. Those are second line following the sequential treatment. Coming to the immune checkpoint inhibitor in the first line metastatic protocol is a keynote protocol of 048 study. Here like head and neck cancer, like oropharynx, oral cavity, hypopharynx, laryngeal tumor. Like they analyze that PD-L1 test and also P16 status. PD-L1 expression also they seen that more than 50%, less than 50%, and also performance status. They use a monotherapy of pembrolizumab and combination chemoimmunotherapy, that is a pembrolizumab with chemotherapy and extreme regimen as a comparative standard treatment was that point of time. Here they use a like a cisplatin and cisplatin or carboplatin 5-FU is a chemotherapy arm. Later pembrolizumab was maintenance treatment was done up to 2 years. You can see here like it has shown that important definitely pembrolizumab monotherapy extreme regimen is slightly OS benefit is there. Hazard ratio is 0.83. And coming to the dose-rami CPS score is showing the more improvement, and CPS score is more than 20%, definitely showing the more improvement in the survival rate, like almost crossing up to 15 months. Coming to the superiority of the chemo with pembrolizumab harm, here you can see here that is 13 months versus the extended regimen of 10.7 months. Shown that is compared to chemotherapy extreme regimen, chemo immunotherapy is superior. You can see here that those are having CPS score more than 1%. You can see here improvement. You can see cursor showing separating is continuing to maintain, and most those are having CPS score more than 20%. Still is going to this combination chemo immunotherapy is going to work. You can see here almost 14.7 versus the 11 months in the extreme regimen. Coming to the monotherapy versus combination therapy versus the extreme regimen, you can see here like there is no like survival benefit, like the marginal benefit like PFS. Actually PFS is the no benefit here between the monotherapy versus extreme regimen. Here like combination chemotherapy versus extreme regimen, the increment in the like there is no much difference between them. Their extreme regimen slightly it's like numerically more number, the response rate is more with the extreme regimen, but PFS benefit was like statistically not significant. They are more or less similar. Coming to the those are having the response rate to the low versus the high PD-L1 expression with the pembrolizumab monotherapy. You can see here those are having a higher the PD-L1 expression. You can see the response rate is more. Extreme regimen try to see the is try to have a response rate is almost 42%. When the PD-L1 expression like low comes in, progression of the disease also more with the monotherapy. That's why PD-L1 expression low, definitely you don't go with the monotherapy, you try to go for a combination of chemotherapy along with the immunotherapy. You can see this like the supporting for that. like PD-L1 expression low, you can see like higher response is better, and low also like you can see combination immunotherapy and chemotherapy 30% of the response is there, and progression of disease also less with the combination of chemoimmunotherapy when compared to the extreme regimen. That's why like you try to have a more surrogate and a lower expression is there, you try to go for a combination treatment. Those are having PD-L1 expression less than 20%. 1 to 20% will go for a chemo immunotherapy. More than that one, wherever possibility is there, you can go for, but disease burden is more, chemo immunotherapy with a monotherapy with the pembrolizumab. There is the protocol is there like the low dose immunotherapy with the maternal therapy from the our TMH protocol. See here, like the exhausted with the multi-line treatment. Actually, here the phase 3 randomized study, they use a TMH like oral methotrexate of 9 mg per meter square, celecoxib and narlotinib, versus along with the nivolumab was used. Flat dose of the 20 mg every 3 weekly was used. Primary endpoint was 1 year surrogate. You can see 151 patient were they used. One arm one is like a 75 patient. Addition of low dose immunotherapy. Arm B is only that is a maternal therapy. With this, you can see here like 1 year, like it is try to see the median OS in the TMH one was 6.7 versus 6.7 versus the 10.1 month respectively. Means those who received a low dose immunotherapy with maternal therapy to try to have a longer disease control. So TMC is only the maternal therapy. TMCI is that is a low dose immunotherapy with the maternal therapy is have a better disease control. This is one of the other options we can try to see. Conclusion of my talk: the standard of treatment of locally advanced head and neck cancer is a concurrent chemo radiation with cisplatin is a standard of practice. Either 3 weekly, that is 100 mg per meter square versus the 40 mg per meter square. Multiple factors are makes the patient unsuitable for cisplatin or high risk cisplatin based treatment going to cause a toxicity. Then there like you can go other alternative therapies. What I said is like other alternative therapy can be available rather than going for a biological agent, or other alternative chemotherapy can be used. There is a protocol like cetuximab didn't have an additional benefit with adding to the chemo radiation. Cetuximab adding to the radiation definitely improve the fiber overall survival rate when compared to radiation alone. Cisplatin nivolumab is more effective in HPV negative head and neck cancer. That is one of the high risk category we can use it. Bulky disease and when we are anticipating we want a more response, durable response, we can use it. Neoadjuvant and chemoimmunotherapy is evolving in neoadjuvant setting. Definitely the protocols are coming, encouraging. I think it is a multidisciplinary discussion with us head and neck surgeon, surgical oncologist, medical oncologist should discuss actually role of a neoadjuvant going for rather than going for direct upfront surgery. This is evolving. Definitely is one of the biomarker for the every individual patient. But more important thing is, see, you might see some progression of disease during neoadjuvant, but we should be every cycle should watch for the any disease local regional control, and any progression is there, like definitely you should surgeon also should in each visit. That is more important. And chemoimmunotherapy or TPS protocol definitely is one of the our important protocol in head and neck cancer. Chemoimmunotherapy, that is a pembrolizumab with a chemotherapy. Like now new protocol is even I didn't because lack of time. Even taxane based treatment also is there, like a taxane based chemoimmunotherapy, that is paclitaxel carboplatin also along with the pembrolizumab protocol is there. Then where the PD-L1 is more combination chemoimmunotherapy is there, we can use that protocol. Or when a cold tumor means PD-L1 is negative, TPX protocol is one of the important regimen in head and neck cancer. There is many unanswered question in best regimen in concurrent chemo radiation in adjuvant setting. especially post induction chemotherapy, because so far we're using extrapolation of the same thing, cisplatin. Still, lot of toxicity failures are there. We may use a biological. We don't have a very right answer. Still, many unknowns are there. Like we are in the future, you might see that newer protocols with newer regimen with immune checkpoint inhibitor. It is going to be a game changer. Thank you. I'll stop here. Any questions that we can able to answer? I can answer.
Thank you very much, Satheesh. That was a fantastic, elaborate, very evidence-based, updated talk. Very nice. Thank you. I'll just ask 3 questions for the benefit of students. Number one, I saw you extensively covered HPV versus non-HPV head and neck cancer. But for the benefit of student, how do you do HPV? Do you want to do it smear from the tumor, biopsy from the tumor, histopathological paraffin blocks, or it is a blood-based test?
Sir, we are going to do IHC based marker, like the P16 is there, like where the tumor biopsy can be taken from a primary site. Maybe the surgeon or head and neck oncologist, they have taken the tissue primary site biopsy has taken, or sometimes human patient has or metastatic is there, like they may be taken a biopsy from the lymph node also. When the primary tumor is very not accessible to biopsy or anything, they might be taken a biopsy from the lymph node. We'll take a IHC from the paraffin block. We'll try to go for the IHC based method. There is a viral test. There is a that is not. That is now ctDNA, selfie DNA of HPV is coming actually, but we are not practicing our insertion. I don't know about other insertion. And there is a like HPV positive that selfie DNA, the baseline and follow up during treatment and follow up of every patient how we are doing in EBV virus like that is there, but we are not practicing. So we are doing that's one of the thing we can do it, but IHC base is more gold standard we are doing.
Okay, now since we know HPV positive negative is different, has it really been clinically managed? Like everybody does HPV and HPV positive, HPV negative, then you decide who should go for surgery, who should go for chemo radiation. So what do you recommend? Is it really a level 1 evidence? Is the treatment totally changed now? Does it practice day to day everybody?
See, we may not change because of practically we are treating in the same way. When early stage that omission of some radiation, some dose can be done in the HPV positive purely, but you should take our Indian patient proper history of habits. There is a mixed population is there, HPV positive and tobacco consumption, smoking, that is more important. The prognosis are similar as a HPV negative people, should be very careful. So far there are no changes in the treatment, maybe some de-escalation small dose of adjuvant setting, the radiation doses can be there, but otherwise the staging system might changes is there, but otherwise the day-to-day practice is the same things. We are waiting for a still longer follow-up of the HPV negative, all those things, but the prognosis wise HPV negative they do bad compared to HPV positive people. Management is so far till today is the same.
Okay. Second thing, for a long time we know that there are no randomized control trial in squamous cell carcinoma, oral cavity, T4 lesion, neoadjuvant chemo by surgery followed by chemo radiation, no survival. Only data is one from the TMH which got published, but it is not a randomized control trial that neoadjuvant chemo in an advanced T4 lesions in squamous oral followed by surgery has a better mandible preservation rate and low recurrence without change in OS. So this question is always asked for students. You have an operable oral cancer CA you operate. You have an inoperable, you go for concomitant chemotherapy. Then there is a borderline resectable. Should you go ahead and do a resection or should you give neoadjuvant operate? What should be the right answer for student in exam?
Sir, like operable, directly go for surgery. Local advanced, like definitely you have to go for a neoadjuvant to understand biology and go for a local definite treatment like anterior like oral cavity. That definitely surgery is a preferred one after the neoadjuvant. Borderline, it has to be multi-disciplinary discussion because there is adding biological. What I said is about that older regimens, the TPX, like it's biological.
No,
along with
the question is advanced oral cancer. Direct surgery or neoadjuvant chemo by surgery, like we have in breast, esophagus, stomach, colorectal. Neoadjuvant treatment followed by surgery. But in head and neck oral cancer only, this has
Yes.
been a work that neoadjuvant chemo doesn't change the limit of resection, no impact on local recurrence, no impact on OS. Why to give neoadjuvant chemo? But now the new data from TMH has come, neoadjuvant chemo. So this question is always there. What do you recommend? Is there any role of neoadjuvant chemo in oral cancer?
Sir, there is a meta-analysis done neoadjuvant chemo immunotherapy right now. There is no much oral surrogate benefit is not there, and most of the all the thing meta-analysis also done neoadjuvant chemo immunotherapy also. What are the with the various number of trials, small phase 2, various number is going to have a margin negativity is going to be improved with the neoadjuvant chemo immunotherapy. So far with the small data multiple multiple data from the meta-analysis. Neoadjuvant definitely is not a routine practice. I'll tell about the is we have to operable straight away. You go with a straight away surgery, but coming in a randomized study that the chemo with the biological agent might change it actually. With the chemotherapy alone, I don't recommend, sir. Go for a chemo alone, go for a surgery. Yes, sir. The biological
like in all other places, is PDL1 required in squamous or before giving immuno, or it is independent of PDL1 in squamous or to give immuno?
Sir, PDL1 is independent. There are the two medications are there. Nivolumab can be used that is there also well studied in the in a recurrent setting. I think irrespective of PDL1, you can use a Nivolumab. But if we're coming to the pembrolizumab, in a recurrent setting, we might use the PDL1. At least 1% positivity is there. We can use that single agent. When you're using combination treatment, irrespective of PDL1 positive, we can use it. But when pembrolizumab data, it's not very favorable with the PDL1 negative. There are extreme data like TPS protocol, we might use it. But when you're going for neoadjuvant or anything, definitely PDL1, you have to see that those people only try to have a more favorable outcome than the PDL negative, even though you are using a combination treatment. PDL1 is a must, sir. Yes, sir.
Second thing, in all other solid tumors which are locoregionally advanced, non-metastatic, there is always a role of adjuvant chemo. Why is it in squamous cell carcinoma, oral cavity, head and neck? Adjuvant chemo alone, we use it as a part of concomitant chemo radiation, but there is no adjuvant chemo at all. Why is it so? In all other field, if you see that either a total neoadjuvant protocol has come, whether you go to esophagus, stomach or rectum, now even in colon.
Sir, definitely is a good question.
Why in squamous cell carcinoma, oral cavity, adjuvant chemo has not come into work?
Sir, the main thing is about the toxicity post definite treatment in the head and neck cancer makes that head and neck treatment adjuvant is more toxic, and definitely that a lot of complications are noted post definitive treatment in the form of even post surgery also adjuvant treatment. The majority there the outcomes are better with the radiation, because the majority of the failure rate was noted in the local failure than the distant failure. That's why the local regional treatment is very important than the other subsite what we see in the systemic treatment is very important. That's why systemic treatment, adjuvant treatment is very successful in the various other subsite. Here head and neck side, except in the nasopharyngeal cancer, there it is a more of lymphomatous spread is more common. Actually there is the access systemic disease. Now induction treatment is very pronounced and is a very good outcome in nasopharyngeal cancer. But in head and neck cancer, other subsite the adjuvant treatment is experimental. Lot of trials are there. There's no change in outcome. There's only adding more toxicity. That's why it's not practiced. Now even they tried with oral metronomic therapy, TMS, there are oral. Those are completed CTRT, CR. There are all the things was tried. Still is adding toxicity without any benefits. And now I wanted to add in the adjuvant setting. Now those are having a high risk category. The post definitive treatment still residual disease there, baseline high risk that now immunotherapy is going to come in a picture, sir. Avelumab is going to have having the positive results so far right now, but we are waiting for a still more longer follow-up. Those are residual disease, like then definitely they are adding maintenance treatment with avelumab and immunotherapy, various other drugs, other immunotherapy, pembrolizumab also is coming in a picture. There they might come in a change in a picture, but cytotoxic chemotherapy is not been successful in head and neck cancer. Maybe most important is, yes sir, local regional failure is more common than the distant failure. That's why that not successful. Post CTIT, the toxicities are more. That's why they're not successful. So what I remember. Sir, you can add it anything here. Yes sir.
No, absolutely. You're absolutely right. In oral CS commas, even in a stage 4A or 4B, systemic metastasis is less than 4%. Lung, liver, bone metastasis is less than 4%. So when there is a disease which behaves and follows Hallstein principle, these are the squamous cell carcinoma oral cavity is one of the few cancers still follows the Hallstein principle: primary, advanced, mandible involvement node, second line node, third line node, then only systemic mats, and rarely. That's why this is a patient people die of locoregional and systemic mats is very low. Unlike oropharynx, hypopharynx, post-record where it is very close to 20-30%. That's why systemic chemo is not being of help, because the chance of systemic disease in squamous oral is extremely low. That's why it has not. I agree with you. So good surgery and radiation coupled with chemo radiation is of like. Thank you very much, Satheesh. That's fantastic coverage. As I always say, from DNB board student and myself, we can't give everything. You have everything in life. You have a name, fame, and good, everything. We can just give a blessings to you and your family for the beautiful work you did for the benefit of students and their teaching. Thank you very much, and heartfelt thanks to you. And over to you, Amit ji.
Thank you, sir.
Thank you, technical for putting on the record on the second. Thank you, sir.